Welcome everybody to the Virginia Chiropractic webinar on chiropractic best practices, understanding Medicare guidelines, and your LCD. My name is Lisa Majeski West, and I will be your facilitator today. This is the third in a series of webinars that I have been presenting to my friends at the Virginia Chiropractic Association, and I always feel very, very honored to be here with you today and work with you on these different guidelines that we've been discussing throughout the month of February. Hopefully this one will be as informative as the last two have been. And for those of you who have not been on previous calls and previous webinars, we have done two on certain guidelines that are used to help doctors with treatment parameters for certain types of medical conditions. The first webinar we did was on the CCGPP guidelines for treatment of low back pain. Then the second webinar that we did in the middle of February was on the CCGI, the Canadian guidelines, and the Ontario protocols for treatment of neck pain and neck associated disorders and whiplash associated disorders. And so this last webinar of our series is dealing with the guidelines that Medicare has established as a result of many of these studies that we talked about to help chiropractors better manage their Medicare patients' treatment plans and to help chiropractors understand where the delineation is between a patient under active treatment for Medicare and under supportive care for Medicare. And so we're going to be discussing this extensively today. If I would just have somebody in the audience, I have you all muted, and I'll keep you muted until the end of the presentation, at which time I'll go ahead and open the presentation up for questions and answers. If you do have any questions that you would like to ask at the Q&A, please go ahead and type it into the chat box so we can just run through the questions very quickly. I'll open up the audience to be able to talk back and forth so we can discuss things verbally as well. I keep everybody on mute so there's not a lot of background noise. We are recording this webinar, and so if you have to leave early or if you have another friend or colleague in the Virginia Chiropractic Association that wasn't able to listen to this webinar, please feel free to have them reach out to either Pam or Julie at the Virginia Chiropractic Association, and they can provide them with the link for this recording. So moving forward now to the presentation, one of the things I do want to let you know is that I have put some sample forms and documentation forms into this presentation. Please understand that these are forms that that you would need to vet with your own state association, that this is not meant to be a legal document, and so please make sure you check before you utilize these forms for the efficacy of them. But they can be used as good illustrations, and of course any forms that I have that I show you on this presentation will be available to you on request. All you'll have to do is email me. And again, at the front page of our presentation, it has my email address. You should have handouts. I've received handouts with this information. And so please feel free to email me for any of these forms if you would like to obtain copies of them at the end of this presentation. So let's first talk about why we are so concerned with making sure that when claims are being billed out, they are being billed out correctly. I don't know if any of you have ever paid much attention to a CMS 1500 claim form. It is a paper version of a claim that can also be submitted electronically, and these claim forms have essentially different data fields that you would type in patient information or fill in patient information from your computer, in order to send a claim to an insurance company, whether it's Medicare or for a commercial claim. And there are 33 boxes and sub-boxes within a CMS 1500 claim form. And there's a very important box, box 31, that is the box that you as the physician or as the doctor of chiropractic sign to validate that the encounter that you are billing for is correct and true. And if you've ever read the back side of the red and white CMS 1500 claim form, the fine print of this claim form says that in submitting this claim for payment from federal funds, I certify, number one, that the information on this form is true and accurate and complete. Number two, I have familiarized myself with all applicable laws, regulations, and program instructions which are available from the Medicare contractor. And number three, I have provided or will provide sufficient information required to allow the government to make an informed eligibility and payment decision. Notice, anyone who misrepresents or falsifies essential information to receive payment from federal funds requested by this form may, upon conviction, be subject to fine and imprisonment under applicable federal laws. So essentially, when you're signing a claim form, a Medicare claim, you are attesting that you are not in violation of the False Claims Act. And so it's very important then that you are familiar with the applicable laws, regulations, and program instructions that Medicare gives you for true and accurate claims on your Medicare patients. I don't know if any of you have been subject to a Medicare audit, but if you have, they're not fun. Medicare audits are definitely on the rise. And part of the reason why Medicare audits are on the rise is because of a study that Medicare did through their CERT audits, which are comprehensive error rate testing audits. And they published their findings in a quarterly compliance newsletter about now 5 years ago. And it was right about this time that Medicare audits really began to accelerate for doctors of chiropractic. And essentially what this quarterly provider newsletter was a guidance to address billing errors. And there were a number of medical specialties in this guidance, but there was a special study done, and this is a copy of the entire document that shows the comprehensive error rate testing on chiropractic services. And I'm not going to make you read all of this, but if you ever want to go to Medicare and get a copy of that special study, you can go to cms.gov and type in the search engine the name of the document. Coming back up to the front is the Medicare Quarterly Provider Compliance Newsletter, April 2013, Volume 3. And this is what would the full document for this would be in this volume. And so here are some of the highlights of this CERT audit. Number one is the majority of claims, chiropractic service claims errors in the audit, in the CERT audit that was done, were the result of insufficient documentation. And they rated 72.9% of chiropractic documentation notes had insufficient documentation to prove medical necessity for the 3 codes that are covered by Medicare for chiropractic services, which are 98940, 98941, and 98942. Insufficient documentation. The rest of the audit basically said that the documentation, some of the errors, common errors, were that the documentation submitted did not adequately describe the service defined by the CPT code. The documentation didn't include the date of service or the beneficiary's name, and this is particularly problematic with doctors who submit travel cards or paper documentation that gets either cut off when it's sent to Medicare, or the information is just not present on those travel cards or on the paper documents. There was no treatment plan documented to support a plan of care. The signature was illegible. And then the other errors in the special study were categorized as medical necessity errors, and these were based on the Medicare coverage policies. And so, it's funny because when I talk to doctors of chiropractic about this who are concerned about being audited by Medicare, I take them to this study, and they say, well, what do you mean the Medicare coverage policies? They don't even know that there are coverage policies out there available and for chiropractors. And so a common reason for the medical necessity errors was that the medical records did not support the need for the service based on the Medicare national coverage determinations and local coverage determinations, or LCDs. And this is where we're going to spend quite a bit of time in this particular webinar, is discussing what those LCDs are, what they say, and how those LCDs can guide you into proper treatment parameters for your Medicare patients. And so this is where the impetus for this webinar is coming from, is as a person who has been involved in the chiropractic field for over 36 years, I know that chiropractors as a whole, not everybody, but 72.9% is what Medicare, and the special cert study took over 50,000 chiropractic claims. Okay, so 72.9% over 50,000 claims. I could probably venture to guess that of the folks that are listening to this webinar, there is a large majority of you who are not documenting medical necessity properly for your Medicare patients. The cool thing about this is that if you do learn and get a hold of how to properly document medical necessity for a Medicare patient, you are going to be safe on the commercial payer side as well, because the Medicare standard for documentation is what is generally adopted by the commercial payers. And so if you can get a handle on this and you can know what Medicare is expecting of you, then you not only can you fight Medicare denials if you are documenting properly, but you can do the same thing on the commercial payer side, and that will help your revenue overall. Now, Medicare has a number. When you're submitting claims to Medicare, you are not submitting your claims to CMS. You're submitting your claims to a Medicare Administrative Contractor, or a MAC. And your MAC for the state of Virginia is Palmetto GBA, Government Benefit Administrators. And every MAC that you see here on this map has an LCD, or local coverage determination document, for chiropractic services. Now, there is an NCD, or a National Coverage Determination document for chiropractic services, that most of the MACs adopt, but then on top of that, they have the latitude to expound on that and to be more specific than the National Coverage Determination documents. And so as we do, our company, Gold Star Medical Business Services, does billing for doctors all over the United States. And we have worked with every single one of these Medicare administrative contractors. And one of the first things that I do when we take on a new billing client is I ask them if they have an LCD, and they know what their LCD says for billing Medicare. And most of the new clients that we take on have no idea what I'm talking about when I ask them about an LCD. And so when I show them what that LCD is and what it says, it opens up a whole world for them on, wow, now I know how to correctly bill Medicare and how to correctly bill for my commercial claims. So for you, you're going to be getting your LCD directly from Palmetto GBA. And I went on to the Palmetto GBA to show you what the Palmetto GBA website looks like. And so if you were to do a Google search and you were to pull up the home page of Palmetto GBA, you'll see that the website for your Medicare administrative contractor has has a wealth of information for you. Number one is it allows you access to a provider portal, and that provider portal will allow you to do a number of things, and I'll show you what that provider portal looks like here in just a minute. You can look up your fee schedule for the 3 codes that Medicare covers, the 98940, 98941, and 98942. You can go to Palmetto GBA, and if you want to know what the fee schedule is for 2018, and the fee schedules change every 6 months, so you would look at 2018A between now and the end of June, 2018B in July. You can look up your fee schedules. If there are updates that you need to know, those updates will be posted on the homepage. And so one of the big updates that's coming up with Medicare right now is that all Medicare patients are going to be issued new Medicare cards starting in April and moving through April of 2019. So over the next year, you're going to need to be asking your Medicare patients for their new red, white, and blue Medicare card, because those cards are going to contain new numbers. This is part of the Social Security number removal initiative that the federal government and Medicare has launched to remove Social Security numbers from Medicare cards, so that Medicare patients are among the top American population that is involved, that are victims of identity theft. And so one of the ways to combat that is the Social Security number removal initiative from the Medicare cards. It also allows you to look up your LCD, to enroll in Medicare or update provider enrollment. So basically, this is your MAC carrier's website is the one-stop shop for you to do everything that is involved with Medicare, and that includes certain Medicare Advantage services. The fees change July 1st. So you're in the, there was a question about that just popped up on the chat. The 2018 A fees will go from January 1st to June 30th, and July 1st through December 31st would be the 2018 B. So you want to always look up the fee schedule again, July 1st, to see if there is a difference in the Medicare fee schedule. The next thing that you'll see is the Palmetto GBA e-services. So if you go back, I'm going to go back up to the home page. At the very top of your Palmetto GBA website, you'll see a link in the black menu bar at the very top. It says e-services, and e-services is your provider portal. And so in order to get into that provider portal, you're going to need to register. Now, this is a very powerful tool for you to help manage your Medicare patients. Through that provider portal, you can log in to view eligibility. So this would tell you if the patient has Medicare Part B, or if they have a Medicare Advantage plan that you should be billing instead of Medicare Part B. You can go through your e-services portal once you're registered and type that patient's Medicare ID in, and it will tell you if the Medicare patient has Part B, if they have only Part A, if they have a Medicare Advantage plan, and if they have a supplemental carrier. The other thing you can do is, for your billing office, they can check claim status on Medicare patients. So if Medicare hasn't paid on a claim, they can go into the e-portal and find old EOBs or check claim status to see if the claims have been accepted or not. They can also conduct online appeals and reconsiderations and redeterminations. So all of that is done through your e-services portal. So please make sure that you have a registered account with your e-services portal through Palmetto GBA. Now here is the 2018 A fee schedule for chiropractic services for Virginia, and when you pull up the fee schedule, you'll see that your 3 codes are listed twice. One has a hashtag next to it, and that would be the fee schedule if you were rendering the services in a facility setting like a hospital. So for the majority of you, this is not going to be the fee schedule that you choose. You're going to choose the fees for the 98940, 98941, and 98942 from the fee schedule row that does not have the hashtag. And so essentially, this gives you the participating fee schedule, the non-par fee schedule, the limiting charge, which if you are non-par, this is the maximum amount you can charge a Medicare patient. If the EHR and PQRS limiting charges are the maximum amount you can charge a Medicare patient if you did not participate in meaningful use or PQRS in 2016. So if you didn't participate in 2016, then these are your limiting charges, okay? And if you let's say you participated in meaningful use but not PQRS, then you would do the PQRS limiting charge. If you did not participate in meaningful use and PQRS, your limiting charge is $29.90, okay? And so that would be for a 98940, for 98941, and 98942 is according. So in your handouts, you should have now the correct fee schedule for Virginia for the 3 codes that Medicare would cover under Medicare Part B services. So just to reiterate, for those of you who are new to Medicare billing, Medicare Part B only covers 3 codes, the 3 spinal manipulation codes, the 98940, which is the chiropractic manipulative therapy 1 to 2 regions, 98941, 3 to 4 regions, 98942, 5 regions. All other services performed by and referred by a chiropractor are not covered. Okay, and this comes directly from the Medicare Quarterly Compliance Newsletter that I showed you earlier, and this is the ICN number 908625, April of 2013. Now, how AT modifiers will affect claims is for the 3 spinal manipulation codes that you bill. In order for Medicare to consider them for payment and to consider them for payment as medically necessary, you must append them with an AT modifier. And so the AT modifier should not be used if the therapy is for maintenance therapy, and if you are billing them because the patient has chosen option 1 on their ABN form. And we're at the end of the call today, we're going to talk about the ABN forms and the practical and the applicable applications of how to use the ABN forms. So you can bill 3 codes. If you bill them to Medicare as active treatment, you have to use the AT modifiers, or Medicare will not pay them. Medicare pays based on the billing and treatment parameters that are outlined in the local coverage determination document. And as I said, individual MACs, such as the Medicare Administrative Contractors, can expand on an NCD, which is the National Coverage Determination, to help and explain and guide certain specialties through correct coding, billing, and documentation processes. And chiropractic is one of them. There are LCDs for just about every different type of medical service that you could think of. So, for example, if you're listening to this and you have a multidisciplinary practice and you're doing injections, you have a nurse practitioner and you're doing large joint injections, there is an LCD for that. And so you need to be following that LCD for how to code for and how to bill for those large joint injections, and you know what the applicable services are. So you have to make sure that you know what your LCDs are for any services that you bill Medicare for, whether it's just chiropractic or if you're in a multi-specialty type of practice, there may be LCDs for other types of services that you bill for. So be aware of that. For chiropractic services, we're going to spend a few minutes talking about the highlights of your LCD, and I've just basically copied and pasted right out of your LCD to discuss what Medicare deems to be a medically necessary treatment for the chiropractic patient. So what Medicare says is that a patient For chiropractic services active treatment, that means AT modifier, the patient must have a significant health problem in the form of a neuromusculoskeletal condition necessitating treatment, and the manipulative services rendered must have a direct therapeutic relationship to the patient's condition and provide reasonable expectation of recovery or improvement of function. Now, if you've been listening to me on the last two webinars, we have really focused on functional improvement, on documenting functional outcomes, and Medicare has embraced this wholeheartedly. So if all you're doing is documenting pain on a Medicare patient and you were audited, most of your claims would be denied. Okay, and I'll show you some wording that relates to that just the presence of pain in your documentation is not enough most of the time to justify medical necessity for chiropractic claims. They will, your LCD considers 3 instances in which Medicare would consider medical necessity for a chiropractic patient. An acute subluxation, which is considered acute when the patient is being treated for a new injury identified by x-ray or physical exam. The result of chiropractic manipulation is expected to be an improvement in or arrest of progression of the patient's condition. A chronic subluxation, and we've talked about in prior webinars about documenting for chronic conditions and how challenging it can be. And your LCD says that a patient's condition is considered chronic when it is not expected to significantly improve or be resolved with further treatment, as is the case with an acute condition, but where continued therapy can be expected to result in some functional improvement. Again, that word function is being used. Once the clinical status has remained stable for a given condition without expectation of additional objective clinical improvements, further manipulative treatment is considered maintenance therapy and is not covered. And then finally, they do consider an acute exacerbation is a temporary but marked deterioration of the patient's condition that is causing significant interference with activities of daily living. Again, we're getting back into function due to an acute flare-up of the previously treated condition. The patient's clinical record must specify the date of occurrence, nature of onset, or other pertinent factors that would support the medical necessity of treatment. As with an acute injury, treatment should result in improvement or arrest of the deterioration within a reasonable period of time. So the question you have to ask yourself is, looking at these definitions of medical necessity for a Medicare patient, does your documentation show this clearly? Does it show this clearly? You need to ask yourself that question. Medicare, your LCD goes on to say that maintenance therapy includes services that seek to prevent disease, promote health, and prolong and enhance the quality of life, or maintain or prevent deterioration of a chronic condition when further clinical improvement cannot reasonably be expected from continuous ongoing care, and the chiropractic treatment becomes supportive rather than corrective in nature. The treatment is then considered maintenance therapy, and at that point, that's when you're having your patients sign their ABN form and giving a choice as to whether they would like to have Medicare continue to be billed, pay cash for their services, or not have the treatments. And again, we'll go through that in more detail here in just a little bit. So what they're saying here is that you may have chronic patients and they come to you from time to time, and you know they have an increase in pain, but it's not really affecting their functional outcomes. It's not really affecting their ADLs. You know, they're just waking up stiff and sore, and an adjustment will help them immediately, and then they can go their way, and maybe 2-3 weeks later they come back. But you cannot prove through any type of functional outcome or through limitations of their ADLs. This is considered, it says, when further clinical improvement cannot reasonably be expected from continuous ongoing care, the treatment is considered maintenance therapy. And in that case, you would not continue to bill Medicare with that AT modifier. You would have to let the Medicare patient know that this is supportive care or maintenance therapy. And one of the biggest areas of takebacks in Medicare, for chiropractors on Medicare claims is using the AT modifier for too long and treating the Medicare patient for too long under active care when they should have been cut loose to supportive care. It basically also says that no other diagnostic or therapeutic services furnished by a chiropractor or under the chiropractor's order is covered. Period. It's very cut and dried. No x-rays, no therapies, no exams. Now, there are things in the works to hopefully change this and to give chiropractic full access to all services that chiropractors do cover, and as part of it is because of the PPACA, this Medicare policy is actually discriminatory to chiropractors, and so there is talk about expanding chiropractic coverage significantly. Personally, I think it's a great thing, but I also think that unless we get a hold of how to do proper documentation, it could be a chiropractor's worst nightmare. Because if you can't document spinal manipulations correctly, how are you going to know how to document E&M codes and x-rays and so on and so forth correctly? Because now the documentation burden is going to be even higher for chiropractors rather than lower. And so, my mission in life, of course, is to make your jobs easier and to make sure that you're getting paid for what you do. And so learning how to utilize these documentations and LCDs and how to understand them is of paramount importance. Please be aware that Medicare does not cover chiropractic treatments to extraspinal regions, that your LCD clearly explains that as well. The 5 extraspinal regions are, and it gives you what those extraspinal regions are. Here's what I was talking to you about as far as your LCD, stating that the mere statement or diagnosis of pain is not sufficient to support medical necessity for treatments. Number 1 is in your documentation, you have to list the precise level of subluxation to substantiate a claim for spinal manipulation of each spinal region, okay? And of course, you as chiropractors know what those spinal regions are, but the LCD outlines it for you in case you're wondering what they consider to be what those spinal regions are. And within the thoracic, the costovertebral and costotransverse joints of the ribs are considered spinal, so that it's important to know that. So for Medicare purposes, you have to place the AT modifier on your claim when providing services. Now, one of the things that the LCDs do also is it gives you a list of approved diagnosis codes. Now, one thing I find very, very interesting about the LCD for Palmetto and for Virginia is that these are the only diagnosis codes that are listed on your LCD. Now, I'm going to tell you, other LCDs have extensive lists of approved diagnosis codes, and they actually classify them into, and your LCD has group 1 codes, but you are missing the groups 2, 3, and 4 codes that other LCDs will have. For example, Noridian, Novitas Solutions, they will actually group the diagnosis codes, which are usually your associated signs and symptoms, or your manifestation codes, your manifestation diagnosis codes, into 3 other groups. And then those groups will define whether a patient would be recognized for short-term treatment, medium-term treatment, or long-term treatment. And some LCDs even give you numbers of visits, such as short-term treatment being up to 12 visits, medium-term treatment being up to 20 visits, and long-term treatment being up to 30 visits. But your LCD does not do that. And these are the only diagnosis codes that are listed. Now, it doesn't mean that they're the only diagnosis codes that you can use, but they are the only diagnosis codes that you can use as the primary diagnosis. In position 1 of box 21 of your claim forms, if you have any other diagnosis code other than one of these 5 diagnosis codes, your claims will be denied by Medicare as not medically necessary. So you must make sure that you are using either an M99.01 through 05 on your diagnosis code sequencing, and that you have diagnosis codes that relate to those subluxation areas to support medical necessity. So for example, if you have M99.01 as your primary diagnosis, you should have some type of a cervical condition like cervical degeneration, disc degeneration at C45 in as the second diagnosis code to relate to that M99.01. Your LCD only recognizes these 5 codes in the primary position for chiropractic services. Now, your LCD also provides the documentation requirements for both initial treatment and subsequent treatment. The documentation requirements under your LCD state that the patient's medical record must contain documentation that fully supports medical necessity for services included within this LCD. And this documentation includes, but is not limited to, the relevant medical history, physical examination, even though Medicare doesn't pay for it, and results of pertinent diagnostic tests or procedures. Chiropractic care is focused on the treatment goals outlined in the plan of care. What is the plan of care? For you as a chiropractor, that is the written treatment plan that you are providing your patients to let them know how you are going to treat them. And the plan of care should be individualized for each patient and should include the following: recommended level of care, which is duration and frequency of visits, and specific treatment goals. I'm going to tell you that when I do audits on chiropractic doctors of chiropractors documentation, and many times I will get calls from chiropractic doctors and chiropractic offices, and they'll say, you know, Lisa, can you take a look at my documentation and tell me where I have deficiencies in my documentation, because I would rather have you audit me before they do, before the insurance company does. And if I do have deficiencies, I want to show the insurance company that I am making improvements to my documentation. This is probably where I see the biggest deficiency in chiropractic documentation, is the absence of a written treatment plan and specific treatment goals, and then the absence of a relating back to that treatment plan on subsequent visits, so that there is not enough documentation relating back to the original treatment plan in subsequent visits to show or prove that the treatment plan is being followed and that the specific treatment goals are being met. And so the other thing is that the plan of care needs to have objective measures to evaluate treatment effectiveness with qualitative and or quantitative measures. And of course, you know, in the last 2 webinars, we talked about these measures. We talked about using the Oswestry Disability Index or the Neck Disability Index, the NDI, the VAS, pain scales, measurable documents that are measurable types of measures that will show the improvement in the patient's function and the improvement in the patient's ADLs. So, you know, you need to make sure, and hopefully what you're seeing in these documentation requirements is everything we talked about in the first 2 webinars as far as utilizing the guidelines for treatment of low back pain and the guidelines for treatments of neck-associated disorders. All of this is being wrapped into these LCDs for chiropractic care for Medicare patients. And again, remember that if you're following these types of documentation requirements for Medicare, if it's good enough for Medicare, it's good enough for the commercial carriers. So really and truly, it's not like you have to learn two different documentation systems. Learn to do it this way with your Medicare patients, and then anytime you have questions or issues about insufficient documentation with commercial payers, you'll have a lot of meat on the bones to be able to appeal claims or argue that, you know, we are documenting our services in accordance with federal guidelines. How can you as a commercial carrier tell us that it's not good enough? Because they have to follow the same guidelines. So if you're doing a documentation self-check, ask yourself this question: do you have a written plan of care for each of your patients? Not just Medicare, but for your commercial patients and even your cash patients, because you want it all to be the same. Is the plan of care individualized, or are you too cookie cutter? Are you doing 36 visits for every patient regardless of whether they need it or not? Does the treatment plan contain duration and frequency of visits? And are you documenting treatment goals? And are there objective measures used as benchmarks towards those treatment goals? Under your LCD, specific recommendations for home programs, lifestyle modifications, for ongoing amelioration of musculoskeletal complaints should be provided as early in the course of treatment as possible and should be reinforced at each visit and documented in the medical record. This is another big area of deficiency in chiropractic documentation for subsequent visits. I mean, my goodness, you hardly ever see in the documentation the guidelines or the documentation just doesn't show any mention that you've discussed this with the patient. Even though you probably have, you need to document it. For patients who have not achieved the goals documented in the plan of care, the practitioner should then conclude the episode of care in the last visit by documenting the clinical factors that contributed to the inability to meet the stated goals. So, are you releasing and referring a patient if they're not meeting their treatment goals? Ask yourself that question. The precise level of subluxation must be specified by the chiropractor. Are you documenting the precise level of subluxation? The level of spinal subluxation must bear a direct causal relationship to the patient's symptoms, and the symptoms must be directly related to the level of subluxation that's been diagnosed. And the need for a prolonged course of treatment must be clearly documented in the medical record. Treatment should result in improvement or arrest of deterioration of subluxation. And this is mentioned quite a number of times throughout your LCD, is this improvement or arrest of deterioration of symptoms of subluxation. So again, documentation self-check. Look through these 5 items and ask yourself the question is, are you meeting the criteria for sufficient documentation for medical necessity? So let's get into the specifics. The documentation requirement of your history for your patients would be, number 1, the symptoms causing the patient to seek treatment. And we know that as a chief complaint. So every medical record should start with a chief complaint. Why are you here today? What is it that is causing you to seek treatment? And remember that the history is coming from the patient. And you, as the practitioner, or as the practitioner's office, are reviewing this history with the patient. And then your objective assessment is going to be a confirmation of, or maybe the patient says that they have this pain, but you're going to do tests to confirm or not whether this pain is valid or not. And so you're going to go through this history, a family history if relevant. I know in a lot of chiropractic offices that family history may not be relevant. However, for example, if you have female patients that are peri or postmenopausal, and there is a history of osteoporosis, that would be a good thing to mention within the family history, of course. Past medical history, mechanism of trauma, quality and character of symptoms or problem, onset, duration, intensity, frequently, location, and radiation of symptoms, aggravating or relieving factors, and prior interventions, treatments, medications, and secondary complaints. Ask yourself this question: does your consultation form or do your patient history forms address all of these issues? And if not, then you may need to shore up that documentation so that you can take a complete history on a patient if warranted and if necessary. The documentation requirements under your LCD for an initial visit would be the history as stated above, the HPI, which is the description of present illness, including the mechanism of trauma, what happened to cause this problem that you're having, the quality and character of symptoms or the problem. Again, the onset, duration, aggravation or relieving factors, prior interventions. And then an evaluation of the musculoskeletal and nervous system through either physical exam or an X-ray to substantiate subluxation. And there are two ways that you can substantiate subluxation for a Medicare patient, and that would be through a part exam or through X-ray. The diagnosis, the primary diagnosis, must be subluxation, including the level of subluxation either so stated or identified by a term descriptive of subluxation. Such terms may refer either to the condition of the spinal joint involved or to the direction of position assumed by the particular bone named. So it gets very, very specific as to what your documentation needs to look like and what words need to be in your documentation to justify medical necessity of a subluxation. You need to have a treatment plan, which should include the following, and we already talked about that: the recommended level of care, specific treatment goals, and objective measures to evaluate treatment effectiveness. Now, let me tell you this: if you're having a Medicare audit and you send Medicare documentation of your initial visit, and this information is not in there, every single claim from the minute you see that patient to the minute you've completed treatment becomes denied. Without a treatment plan, every visit is denied because you did not fulfill the burden of responsibility of documenting medical necessity in that initial visit. So you have got to get that treatment plan in there, as well as those treatment goals, and then of course the date of the initial treatment. And those are your documentation requirements. And these are the documentation requirements that Medicare auditors, whether you go under an SMRC audit, which is a supplemental Medicare recovery audit contract, or a recovery audit contract, or an RA audit, this is what the auditors use. It's cookie cutter. They're going to take this information and they're going to look at your documentation to see if it meets the burden for documenting medical necessity. For subsequent visits, which means every visit after the initial treatment, this is what your documentation needs to look like. An interval history sufficient to support continuing need. Okay, you don't have to go through the complete history like you did in the first visit, but an interval history sufficient to support continuing need, documenting any substantive changes, review of the chief complaint, changes since the last visit, a system review if relevant. ROS is not necessary on every subsequent visit, but if it is relevant, then especially if there are changes since the last visit, you may want to do a ROS on certain systems. Physical exam, interval documenting subsequent changes. A full repeat of your part exam is not expected, but you would examine the area of the spine involved in diagnosis through palpation, and of course you would mention that in your documentation is how did you do that assessment? Assessment of the change in patient condition since last visit, and evaluation of treatment effectiveness. Patient is responding to care as outlined in the original treatment plan. Patient has not responded to care due to non-compliance. They've missed 2 or 3 visits, of course, and all of that you would want to document as part of the treatment effectiveness. Documentation of treatment given on that day of the visit, what what did you do, spinal manipulation, and if you did other therapies, you could document that as well, even though they're not paid for, and documentation of how the day's treatment fits in with the plan of care. For example, visit 4 of planned 7 treatments, and any way the treatment plan is being changed. So all of this needs to be present in your documentation requirements on subsequent visits. Now, if you're using X-ray to document your subluxation or to document medical necessity versus the part exam, the LCD states that the X-ray may be used to document subluxation. It must have been taken at a time reasonably proximate to the initiation of a course of treatment. So the question is how old are your X-rays? It does say that unless more specific X-ray evidence is warranted, it states that it is reasonably proximate if it was taken no more than 12 months prior or 3 months following the initiation of a course of chiropractic treatment. It does go on to say that in certain cases of chronic subluxation, an older X-ray may be accepted, okay, if the condition has existed longer than 12 months and if there's a reasonable basis for concluding that the condition is permanent. Okay, so it doesn't mean you have to take X-ray every 12 months, but you know, if you haven't taken an X-ray on your patient in 3 years, I would say that at that patient's age, there's going to be further deterioration of their condition, and I would be taking an X-ray on a fairly routine basis for your patients. Okay. A previous CT scan or MRI is acceptable if a subluxation is demonstrated, okay? And also make sure that you have a written radiology report. If you are using X-ray to document subluxation, have a written radiology report that can go with your requests for notes, should you be audited, which hopefully you won't be, but should you be, you would want to have that. So what is the part exam? The part evaluation is an acronym for having certain elements of the documentation of the exam met, and it is PART. P stands for pain and tenderness, it stands for asymmetry, misalignment, R stands for range of motion, abnormality, and T stands for tissue and tone changes in the characteristics of soft tissues, including skin, fascia, muscle, and ligament. And you can see within your LCD that they identify what you would need to document in your part exam in order to justify medical necessity for a spinal subluxation for Medicare patient. Now, it states here in the part exam to demonstrate a subluxation based on physical exam, 2 of the 4 part criteria are required, one of which must be asymmetry, misalignment, or range of motion. So you can have P and A, P and R, you can have T and R, T and A, but you cannot have P and T as the only criteria. You must have at least asymmetry or range of motion documented within the physical exam to document medical necessity under part. Okay. Your treatment plans, you want your treatment plans for a Medicare patient and for all patients for that matter to be what I call dynamic treatment plans and not static treatment plans. So you don't do a treatment plan at the beginning of a patient's plan of care for X number of visits. Treat. Don't continue to assess through the course of treatment and then, okay, I'm at the end of the 18 visits. I'm going to do a re-exam at that point in time and then decide if further treatment is necessary. Documentation of changes in the patient's examination, status, and progression must be recorded at each visit. And again, what you're seeing on this screen is word for word what is coming out of your LCD. The evaluation process must be ongoing. Okay, they are requiring standardized measurement scales, visual analog, Oswestry disability, the Quebec back pain disability scale may be used to measure improvement or lack thereof. It states clearly this ongoing evaluation and assessment forming the basis for treatment modification is a key factor in total patient management. Okay, and if you are having a documentation request from Medicare, the LCD states that on request, at a minimum, you must submit the initial visits treatment plan, the concluding discharge visit, and subsequent visits that demonstrate any change in the history, physical exam, or treatment plan. So here's the question. If you were to audit yourself now based on the LCD documentation requirements, what grade would you give yourself? Looking at what these requirements are, looking at how you document your patient encounters, how would you grade yourself? If you're not confident that the documentation that is coming forth from your office would meet the muster of Medicare, then you need to have a discussion with your staff, with yourself, with your other providers on how are we going to improve this to make sure that we are audit proof, and that if we are audited, we're not going to be subject to huge recoupments. Now, before I go through the ABN, and I'm going to do this very quickly and then open up the class for questions, but I want you to understand how a Medicare audit works. A Medicare, if you were audited by Medicare for an RA audit or an SMRC audit, which is a supplemental Medicare recovery contractor or a recovery audit contract, Medicare is going to ask you for about 30 charts, 30 Medicare charts. And you're going to send those charts to a contractor, an independent contractor from Medicare, whose sole job is to audit your documentation. What they're going to do is they're going to audit those 30 charts, and of those 30 charts, they are going to determine an error rate, an overall error rate on your charts. And so they're going to say on those 30 charts, and I think it's 33 charts is the exact amount that they're going to ask for. I don't know why 33, but that's what they ask for. On those 33 charts, let's say your error rate is 70%. So what they're going to say is on these 33 charts, you billed out $3,000 in Medicare. We're going to ask for 70% of that back. But that's not where they stop. What they do then is they extrapolate that error rate out over anywhere from a 2 to 6 year look back period. They can go as far as a 6 year look back period. So then what they can do is they can say, if the error rate is 70% on these 30 charts, then we're going to go back 6 years to everything that Medicare has paid you over the past 6 years and assume 70% of what Medicare paid you is an error, and we're going to ask for all of that back as well. So it's not just going to be the recoupment on those 30 charts. They're going to do an extrapolation audit, and they're going to extrapolate that error rate out over a 2 to 6 year look back period, depending on how severe the documentation errors are. Okay, so that's why this is so important to you, because what we've seen if you go to the OIG and you look at the chiropractic cases that have gone to these types of extrapolation audits, you're looking at hundreds of thousands of dollars in recoupments, civil money penalties, and possible criminal fines, depending on how severe these audits are and how bad you or as the chiropractor fare on these audits. Okay, and it is true whether you are par or non-par, there is no difference. And they are auditing non-par doctors as well. Okay, not as much as the par doctors, that is for sure, but non-par doctors are being audited. So how do you, once you have determined a patient's plan of care, and you know that their plan of care at some point is going to be ending, and you're going to move that patient into supportive care, you must have the patient sign an advance beneficiary notice. Now, a couple of things that you need to understand is that the ABN, the mandatory ABN, is only for the spinal manipulation charges. Okay. One common mistake that I see with ABN forms is that doctors will put everything in the kitchen sink on their ABN, their manipulations, their exams, their x-rays, everything. That is not correct. You actually should have two ABN forms, a mandatory ABN for the spinal manipulations, because those are the only services that Medicare covers, and then a voluntary ABN, which is a notice of non-coverage for everything else. Okay. You don't have to do an ABN for the non-covered services, but it is a very good way to explain to a Medicare patient why Medicare is not covering that therapy or that exam or that x-ray. Okay. And that's called a voluntary ABN. And the same form is used. And I'm going to show you the illustrations of the different types of forms. So when you reasonably expect that a patient is entering maintenance care, you're going to want to have them sign an ABN. And so there are three events that prompt an issuance of the ABN. And this comes directly from the ABN instruction sheets that I sent you as I sent you a whole zip file of ABN samples of blank ABN forms that you can customize for your practice both in English and in Spanish. And so the zip file will contain this, the instructions for how to properly fill out and issue an ABN. Initiations, reductions, and terminations. So the three triggering events that would prompt you to initiate an ABN would be at the initiation of care. So you can have all of your Medicare patients at the initiation of care sign an ABN form, and that's perfectly valid. If you have a reduction in care, so let's say, for example, you have a patient that you initiate care on and you do a visit plan of 24 visits, but halfway into care, they respond better than anticipated. And now you're at a point where it's like, gee, you know, I think we can cut you loose to supportive care. You're going to do a re-exam, maybe earlier than expected, and you're going to reduce the amount of care that you give that patient and let them know that they're going to be going, the good news is that they're going to be able to go into supportive care earlier than expected, and you're going to be able to release them earlier than you expected from the treatment plan. At that point, you would want to reiterate the ABN with them, have them sign a new ABN, or termination of care. So these three scenarios would be scenarios that might prompt you to issue an ABN form. Now, a voluntary ABN would be, and of course, you're not required to notify the beneficiary before you furnish the service that Medicare does not cover or is not a Medicare benefit. You don't have to, but it sure makes it easier to get the patient to pay for it by letting them know in advance that these services are not covered, so they don't get surprised with a bill at the end of their care or after a month of exam fees and x-ray fees that Medicare doesn't pay for. And in that case, then you would put all of those services on the voluntary ABN and have and go over that with the Medicare patient. So this is what the ABN looks like. Now you have to make sure that you are always using the most recent copy of the Medicare ABN. If you the most recent copy of the ABN is it's the form CMS R131 EXP 3 of 2020. So this one is good through 3 of 2020. If yours has any other date other than this, you need to get new ABNs on all of your Medicare patients. Okay, so this came out in June of last year, and so since June of last year, you should have been using this ABN form. And if you haven't, then this is a good time of year, beginning of the year, you can say to tell the Medicare patients, we need to update your advanced beneficiary notices. Make sure you have the new forms in file, because if you're audited and you have an old ABN, then Medicare can say that it's not a valid ABN. And so this is what the mandatory ABN would look like. You can pre-populate the name of your practice on the notifier. You can pre-populate the boxes D, E and F, and essentially this is what is in the boxes. It's, you know, D stands for spinal manipulations. E is Medicare does not cover supportive or maintenance care, and then you put your fee range in there, and then you would type in where it says D. So if I come back up to the generic ABN, you see D is blank, and so you're going to type in the word treatments. And the treatments are spinal manipulations. You could type in spinal manipulations there, okay? But this is how you would fill out the ABN. And again, you all have samples of this in your handouts so that you can fill these out correctly. Remember that when you do the ABN, the patients have 3 choices. Option 1 means that they want the treatments. If that's the case, then you would continue to bill Medicare. You would remove the AT modifier once they move into supportive care and replace that with a GA modifier stating that there's an advanced beneficiary notice on file, and the GA modifier will then kick that denial to patient responsibility versus a contractual write-off. So that's the importance of the GA modifier, is that if you don't have that GA modifier on there and the patient is under supportive care, then you're going to get a denial, but it's going to be a contractual write-off. So make sure that you have that GA modifier on the claim if they choose option 1. If they choose option 2, they can convert to cash and be charged the cash fee. If they choose option 3, you're saying that they don't want the treatments at all, and then you would advise the patient the parameters under which they should come back if they're feeling, you know, if they begin to see an increase of symptoms, a decrease in their activities of daily living, that they should make an appointment to come back for treatment of a chronic condition. And then at that point, you put them under the AT modifier under a micro treatment plan. Okay, the patient must sign and date the ABNs. This is what a voluntary ABN would look like. So you'll notice that you can have all of your common services. The reason Medicare does not pay is Medicare does not cover these services when performed or referred by a chiropractor. And then you would have a range of fees for the different services. You would strike out the options. They don't choose an option for the voluntary ABN. It is informational only, okay? But they understand that they're responsible for paying the charge for the items. If you look under H, under additional information, you would type in this statement. This supplier does not accept payment from Medicare for the items listed in the table above, and that they know that they're financially responsible for that, and then you would have them sign and date that. So the importance of the voluntary ABN is to make the patients aware that they're financially responsible for these services. If you are a non-par provider, your ABN needs to be written in a little bit differently, and you need to customize it. So the part of the ABN that says, if Medicare does pay, you will refund any payments I made to you, you remove that, because Medicare is sending the payments directly to the patient. And then under the additional information, you have to type in this statement. Okay, and it states, if Medicare does pay, and this is important, especially if you charge the limiting charge for Medicare patients, Medicare will pay me the Medicare approved amount for the items, meaning me, the patient, and this payment to me may be less than the supplier's charge. Okay, so the patient gets paid significantly less than your limiting charge as a non-par provider. And if you have questions about limiting charges, non-par, please feel free to send me an email, and I'll be happy to call you and talk to you a little bit more about that. Consultation questionnaire, again, I showed you there was going to be some forms, and these forms are in your handouts. Again, if you would like customizable copies of these forms to use for your documentation, then please feel free to email me, and I'll be happy to send you a set of all of these forms. This consultation questionnaire covers just about everything under the HPI that you would need, that you can go over with. This is a sample part exam form, so this would be the subjective, the P part of the part exam form. And by the way, just coming back up to this, I have some doctors just take this first page and have their patients will fill this out at every visit. They have to take this page. I've had some doctors who are real tech savvy put this on an iPad, and they have the patients, mark the areas of pain and what kind of pain they have. And this is how they document the subjectives at every visit. And so you can actually use this as a double whammy type of a form, where you can use this for their daily subjectives and also for their initial part exam. And then you have the AR, the range of motion assessment, and tissue abnormalities. So all of this is part of the part exam. Also in the part exam, you have your major chiropractic tests, and this is in a Word document, so it can be customized for your own particular practice. And again, I'm more than happy to supply these for you. This is an example of what a good radiology report might look like. So if you are going to prove subluxation medical necessity by radiology, this is what the radiology report would look like. Sample treatment plans, again, if you need to document a written treatment plan, this has it along with all the treatment goals, lifestyle modification, nutritional support recommendations, and so on and so forth. And if you need any more resources and aids to help you with this Medicare billing and Medicare documentation, this publication, SE 1603, puts all of the Medicare documentation requirements and billing requirements for chiropractors into one comprehensive document. So you can go to cms.gov and type in under forms SE 1603, and it will give you the full document with all of the links. Okay. I know we don't have a lot of time. I'm willing to stay for questions, answers to your questions. I'm going to go ahead and open up the audience now. Let me see who my attendees are. I will unmute everybody. Hopefully I'll unmute everybody. Okay, I'm going to unmute everybody. And let's see what kind of questions we have here. So start down here. So Summer's question was, when do fees change? Which 2 months did you say? Okay, so we addressed that one, January and 1st of July. If we're in network with a carrier, then the carrier guidelines can override federal guidelines. Yes. So view your contracts. Absolutely correct. But what you will find is that most carriers' guidelines are going to be fairly in line with Medicare, because what carriers have found is that if their guidelines are too different from Medicare, it opens up the ability of the state associations and the boards of examiners to question those guidelines and to file class action suits against those carriers, which has been done, and the ACA will do that as well if the carrier guidelines are not in line enough with the Medicare guidelines. And so, and then the question as to whether this was true, whether you're par or non-par, yes, as far as audits go, that is correct. Oh, this is a great question. Can a doctor see a Medicare patient if they're not registered with Medicare? For example, we've been turning Medicare patients away as we are not registered with CMC. The answer to that is you may not treat a Medicare patient if you are not registered with Medicare. And I know that there are companies out there that will say, well, we don't do spinal manipulations, we just do therapy services, or we just do spinal decompression, and they will treat Medicare patients. They're getting in a lot of trouble by doing that. Medicare is coming down really hard on doctors who who are not enrolled in Medicare, who are treating Medicare patients. Whether they are treating them for non-covered services or not, Medicare is seeing it as a way of getting around the system and treating a Medicare patient, because let's face it, a 97140 joint mobilization can be argued to be a spinal manipulation. So some doctors who are not treating, who are treating Medicare patients without being enrolled, and then just having like a a cash-based practice and treating Medicare patients are getting into a tremendous amount of trouble all throughout the country, and Medicare is looking at that as a criminal violation and not just as a billing violation. And honestly, chiropractors have asked me the question, well, how would Medicare know if we're not billing? Well, what happens is a Medicare patient doesn't know, and so they think, well, I know that, this doctor doesn't take Medicare, but I'm going to turn it into Medicare just to see if maybe they'll pay. They don't understand. So they turn the bills into Medicare, and Medicare looks at that NPI number and says, well, we don't have this person registered as a Medicare provider. And then they call you and they say, this Medicare patient just turned in these Medicare claims. And it's usually the Medicare patient that accidentally turns the doctors in, or other chiropractors in your community who know you're not supposed to be treating Medicare patients, but you're trying to get around the system, and then they turn you in. So please, if you do not have a Medicare number, don't treat a Medicare patient. And if you have a patient that ages into Medicare, you're going to have to refer them out. So be very, very aware and very, very cognizant of that. Are there any other questions?